Okay, I'm Dr. Andrea Holthouse, and we are continuing with our palliative care and hospice education today, focusing on symptom management. Sharing my screen. So let's start out with pain. Pain is a common symptom in palliative care and hospice, and a comprehensive pain assessment is very important in understanding what is going on with a patient's pain. A pain assessment helps you build rapport and trust with your patient. It may help in determining a treatment strategy. Really applying a patient's particular experience of pain to a safe and appropriate pain plan can be really helped with a comprehensive pain assessment. It also helps avoid misdiagnosis or unnecessary testing and really identifies those individual patient factors that influence a pain management strategy, as well as the selection of which pain medication and what dose and when to adjust. So the pain assessment, one piece of that is characterizing the pain. And this helps us determine what type of pain it is, which may make a difference in what medications we choose to help treat the pain. So qualities such as sharp, stabbing, burning, or aching. What kind of intensity is it? Is it mild, moderate, or severe? What's their pain score? Where's the pain located? And does it move anywhere? Does it radiate? What makes the pain better? What makes it worse? Is it better when you place a hot pack? Is it worse when they get up? When did the pain start and how long did it last? Was it a brief stabbing episode or it lasted for an hour? And what functional impact did it? How is this affecting the patient's ADLs or their mood or their relationships? There's different types of pain. One type would be somatic pain. Somatic pain is when there's tissue damage to the skin, soft tissue, muscle, or bone. And it's usually described as an aching pain, maybe a deep pain or a dull, gnawing pain. It might also be described as sharp or stabbing. And somatic pain is usually well localized. The patient may be able to point at it. Visceral pain is that pain from the visceral organs, such as the liver, the gallbladder, or the intestines. This is a cramping pain. It may be described as bloating or pressure or fullness. Sometimes it can be a squeezing pain, or the patient may say they're very gassy. It can be referred from other places, or it can be a diffuse pain or kind of crampy, colicky pain, and can also be associated with nausea or sweats. And then neuropathic pain is where there's injury or inflammation of the nerves, often coexisting with either visceral or somatic pain. But patients may describe this type of pain as a burning pain or a lancing electric shock pain, radiating pain, or maybe even shooting or stabbing. And then remembering that pain is what the patient says it is. We're looking at all factors of the person, not just the physical disease, because we should not underestimate the effect of psychological, emotional, or spiritual distress it has on pain management in palliative care and hospice patients, and really being cautious of judgment or categorizing. And really, our job is to help provide comfort. We ask that you chart an approved pain assessment for your facility or your floor. And then when the patient's not able to give you a numeric pain rating scale, to use your approved nonverbal adult pain scale. And don't forget constipation management. Constipation is very common, often unrecognized, and can contribute to agitation, delirium, and pain. And managing this issue is key to a safe and effective pain treatment plan, because there's a lot of common causes of constipation, and one of the common causes of constipation is opioid pain medications. It's very important that we recognize when patients are on opioids that having a bowel regimen is important. Another common cause of constipation, which we see in the palliative care or hospice patient population a lot, is reduced fluid intake or dehydration, or maybe they're eating a low fiber diet, or they're getting weaker muscles, or their mobility is poor. They also may have a lowered consciousness state, and then just disease process itself. So there's a lot of common causes of constipation we might see. Doing your assessment for constipation is important. The patient may have abdominal distension. You may note overflow incontinence, which is where liquid stool oozes around an impaction or an obstruction. The patient might describe a rectal fullness or pressure or discomfort, or they can't pass a stool despite feeling the urge to go. And constipation can also cause increased fatigue. It can contribute to nausea and even vomiting, and also be cause for delirium or agitation. So asking about the bowels is how you do your assessment. Being aware of what medications they're on, what diet and fluid intake they're using, and their mobility status. So which laxative works best? They've done a Cochrane review of laxatives for constipation, and there was no evidence on whether individual laxatives were more effective than others. In our palliative care and hospice patients, we like to use stimulant laxatives. Senokot is one that can be titrated. There are 2 studies that showed that there was no benefit when adding Docusate to Senna for the treatment of constipation in advanced cancer patients. So you'll see in our hospice patients, we don't add Colase or Docusate because it makes the stool too difficult to pass because it's too soft. So let's talk about shortness of breath or dyspnea. What is it and how do we assess it? Dyspnea is subjective shortness of breath and doesn't correlate with oxygen saturation or respiratory rate. We're going to use our observation for assessment. Are they short of breath when they turn or eat or speak? Are they short of breath when they're toileting? Are they using accessory muscles, using those abdominal muscles to breathe? Are they grunting or have an increased respiratory rate? Do they look restless or a look of fear? Are there crackles or wheezing? Patient self-report is a preferred tool, but you'll use your assessment if they are not able to verbalize. And then just remembering that agonal breathing or apnea episodes or that irregular breathing are very common at end of life, and that is not uncomfortable. And also those secretions might be present at end of life that are hard to listen to but aren't causing discomfort. Some non-pharmacologic management, dyspnea would be maybe a position of leaning forward or looking a line of sight out to an open door or a window. Also, a fan blowing air over the face can be helpful. Mindfulness-based stress reduction, and then pursed lip breathing. What about the question, shouldn't my loved one be on oxygen? It is common for families to think the patient needs oxygen when the patient's short of breath, but opioids work significantly better than oxygen to relieve shortness of breath, whether or not the patient's oxygen saturations are low in our patients with dyspnea at end of life. There have been multiple randomized controlled trials and systematic reviews that showed significant reduction in breathlessness with the use of oral or IV opioids. So first line would be to try the opioids. And then pharmacologic management of dyspnea, as mentioned, opioids being the most well-established with multiple expert groups endorsing them. Benzodiazepines decrease anxiety, but we wouldn't use that as the only medications for dyspnea because there's no evidence for it as the only medication, but it is important if there's an anxiety component. And then there's also, as mentioned, poor literature support for effectiveness of oxygen in the absence of a hypoxia, but it is a low-risk intervention in Palliative's families as well as can be comfortable for the patient. And then remembering the disease-specific interventions such as draining the pleurics catheter, do they need steroids or diuretics or nebulizer treatments? Delirium is another common symptom. Delirium would be a acute change in mentation with a fluctuating level of consciousness. Patients may have a change in their sleeping patterns where they're awake during the night and sleeping during the day. They may have incoherent speech or delusions, hallucinations. They could have aggression or confusion, agitation, and then that disorganized activity where they're plucking at their linens or pulling at their clothes, pulling at their lines, drains, and their airways. So there is a mnemonic to help you think about causes because oftentimes with delirium, we need to see if there's a reversible cause. One would be what medications are they on? Did they just get a medication and become confused shortly after that? Emotional is another one, which would be depression, can sometimes be confused for delirium. Low oxygen, is it a blood clot or do they have a heart attack? Is there an infection? Do they have a UTI? Are they retaining urine or retaining stool? Did they have a seizure and this is a postictal state? Are they having dehydration or malnutrition, undernutrition, which could be common at someone who's not drinking very much? Is it a metabolic problem with electrolytes or their thyroid? Or did they have a subdural or a stroke? Just remembering that there are causes to delirium that we should look into. And then also carefully assessing for pain, because sometimes patients who aren't able to verbalize good pain assessment, they might be restless or agitated because they're in pain. And are they wearing appropriate and correct eyewear or hearing aids if they need those? And then what is terminal delirium or terminal restlessness? This is where there's increased agitation and delirium as the patient nears death. It's usually seen a few days before death, and the patients might be trying to get up and down repeatedly. I have to go, trying to get out of bed, becoming very agitated and irritable and unreasonable, and also can be hallucinating and out of control. What are some non-pharmacologic treatments for delirium? When appropriate, try to reorient them to day versus night, like turning off the lights at night when the patient should be sleeping, having the blinds open during the day so it's daytime during the day, creating a peaceful environment, calming music, familiar items throughout the room like family photos, and then speaking in a soft and calming tone and reminding the patient that they're safe. And then medications for delirium, there are the antipsychotic medications like Haldol or olanzapine or Seroquel, and then the benzodiazepines can add on to those sometimes, such as lorazepam. And just remembering a tip to avoid Haldol in Parkinson's disease, which can worsen their movement problems. And then remembering that patients in palliative care or hospice care may be anxious, but it might present differently in serious illness. They might not just say, I am anxious. They may express worry or fear or nervousness or a feeling of impending doom. Maybe you notice they're having trouble concentrating or they're having trouble making a decision on something that they need to make a decision on. You might complain that they can't sleep, or you might notice that they're agitated. They may complain of nausea, or their stomach feels upset, or they feel like they're having some loose stools, or they're not hungry, or they feel like their heart's racing, or very tired. And then just question spiritual, like questioning the existence of God or the meaning of their illness. So there's different ways anxiety can present. Some comfort care tips: don't hold scheduled medicines on hospice patients, on inpatient hospice. Often medications on these patients are being scheduled to try to get a better baseline control of either their pain or shortness of breath or agitation or whatever symptom it is. We also don't give Haldol IM for hospice patients. We give it IV. IM injections are not comfortable. And then if it's ordered IM, that would be something that we would suggest asking if the order can be changed to IV. And then just remembering that opioids are the gold standard for shortness of breath treatment, for that dyspnea treatment, even before oxygen in hospice patients. And then the take-home points are: if you need help supporting patients' decisions, advanced care planning, or symptom management, think palliative care. And if you're thinking about comfort care, think about a hospice consult.